Okay, yeah. Welcome, friends. Good evening to all. Okay, let us start with the 25 most important questions in physiology. Okay, this is solely for the purpose of FMG. Okay, 4th June. Right. Let's come straight to the point. Just see this question. In the following diagram, it represents the sarcomere. This is representing sarcomere. Okay. The area marked as X, what is this known as? The area which is marked as X, if you can see here, then this is X. It is slightly, this is X here. This is the area marked as X. Okay, this is the area. What is this area known as? This area is known as, what is this known as? This area is known as, 4 choices. A band, I band, H zone, pseudo H zone. What is this area known as? This area is known as A band. Okay, this area is known as A band. This is the myosin filament. From here, if you see this myosin filament, from here up to this point. From this point up to this point, it is actually the myosin filament. So this is A band. This okay? Length of the myosin A band. And where A band is not there, that means from here up to the next one, that is I band. So this is I and this is A. Now this portion which will start from here and go up to this point, what is this? This is pseudo H. In the center of the myosin, right in the center of that, this portion, where there are no cross bridges. Okay, absence of cross bridges. This is pseudo H. This okay. H is because of the absence of actin. So H is from this point up to this point, or here in this diagram, from this point up to this point. This is H. In this diagram, H is from here up to here. And in this diagram, H is from this point, this is the edge of actin, up to this point. So the absence of actin in the center of the sarcomere, this is H. Absence of cross bridges, this is pseudo H. And the length of the myosin from here up to here, this is A band. This okay? This portion, this one, or you can say this one, this is actually the I band. This okay? This is just a picture based question. Sarcomere is from this point up to this point. This is sarcomere. Z line, Z line. This is sarcomere. Okay? In the very center, this line can be called as M line. So M line is in the center of the sarcomere. I think it should be clear now. This is M line. This is pseudo H. This is H. H is variable. In this diagram, H is from here to here. And the question which is asked here is actually the A band. This okay? I think maximum students are able to answer. This is not H, this is A. This is okay? Okay. Just see this question. A 40-year-old female suffered from tricuspid stenosis. The prominent A wave was observed in the JVP. Okay, this is because of the prominent tricuspid stenosis. The cause of the A wave is, in the JVP we have 5 waves. What is the cause of A wave? The cause of A wave is atrial contraction. This atrial contraction will lead to A wave. This is okay. The bulging of the tricuspid valve towards the right atrium during ventricular contraction, this is C wave. Venous return, this will lead to the production of V wave. Opening of the tricuspid valve will produce Y descent. If you see it, it is like this: A, C, X, V, Y. These are the wave patterns. A, C, V, this is X, this is Y. Now you can see A wave is because of atrial contraction, this one. The C wave is because of the bulging of the tricuspid valve towards right atrium during ventricular contraction. V wave is because of the venous return, this one. X descent is because of the fact that tricuspid ring is pulled down. During ventricular contraction, when the ventricle becomes short, tricuspid ring is pulled down. So the pressure in the right atrium is decreased. This is X descent. V wave is because of the venous return, and this is because of the opening of the tricuspid valve. So I have repeatedly told this thing in the class. There are 5 waves in JVP, and every wave has a cause. Last year they have asked C wave. You never know. This year they may ask about A wave. So just remember the 5 wave of the JVP and their cause. A wave, simple wave to remember, atrial contraction. This is okay. Atrial contraction, A wave. C wave, bulging of the valve. Okay, these 2 are very important. Other students are confused, so usually they don't ask. But A and C, don't forget that. And in the tricuspid stenosis, the same thing will happen. There are 4 chambers here. Is okay? When this contracts, the pressure here is increased, A wave. When this tricuspid valve is stenosed, suppose this valve becomes small. Okay, this valve becomes small. So when this chamber, right atrium, will contract, the blood, instead of going here, this blood will go backwards in the jugular vein. So A wave will become more prominent. Okay, the prominence of the A wave, maybe this may occur in tricuspid stenosis. I think it should be correct now. This contraction produces A wave. When this contracts, this valve is bulged, C wave. When ejection occurs, this will become small, tricuspid ring will go down, X descent. The venous return will produce the V wave, and when this valve will open, blood will move from here to here. So pressure here will fall again. This is Y descent. Okay. So 5 waves, A, C, X, V, Y. Just remember their causes. So answer here is very clear cut. Atrial contraction. The cause of the A wave is right. Okay. Maximum students are correct here. Okay. Let's go to next question. A student was doing spirometry and the following graph was obtained. The area marked as X is known as, this is X. What is this thing known as? This thing. What is this thing known as? 4 choices: expiratory reserve volume, functional residual capacity, closing volume, residual volume. What is this known as? Easy question. Question is easy. Expiratory reserve volume, functional residual capacity, FRC, closing volume, residual volume. Question here is easy. Yes, question is easy here. This is the functional residual capacity, FRC. Is okay? This thing, this is residual volume, and this is expiratory reserve volume. Residual volume plus expiratory reserve volume. This is a functional residual capacity. This thing is tidal volume, normal in and out. This is a tidal volume. This okay? And what is this? This is inspiratory reserve volume. The volume you can inspire over and above the normal tidal volume. This is inspiratory reserve volume. Is okay? So inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. And this plus this is functional residual capacity, FRC. And this plus this is inspiratory capacity. Inspiratory capacity. And this plus this plus this, what is this? This is vital capacity. We see vital capacity. And all the four combined. All four combined. This is total lung capacity. This plus this plus this plus this. This is total lung capacity. This plus this plus this, vital capacity. This plus this is inspiratory capacity, and this plus this, which is the question which is asked here, this is functional residual capacity. This okay? So I think now the answer is clear. Expiratory reserve volume, FRC, residual volume. Closing volume is a different concept. Closing volume is somewhat over here. Like if I draw it like this, closing volume is a slightly difficult concept. This is closing volume. This is the residual volume stage. This is FRC stage, this is residual volume stage. As I will do expiration, a stage comes, okay, when I will do forced expiration, you will go up to this residual volume. This is okay. So as I do expiration, a stage comes where the alveoli in the lower dependent part of the lung close. So this is a closing volume stage. So it is a slightly difficult concept. This stage is known as closing volume stage. It's okay. So don't be confused related to that. If we become hyper technical, then this is known as closing volume, and this is known as closing capacity. So this is slightly difficult concept. We can ignore that for examination purpose. Okay, so this is closing volume. This entire thing may be closing capacity. Okay, so closing volume will be something like this. This is closing volume. So don't be confused related to that. Don't be confused. Okay, it is slightly difficult concept. I'm not entering into the detail of that. So just ignore that. This okay. So answer here is very clear cut and simple. Functional residual capacity. So for this purpose, just try to remember 4 volumes and 4 capacities. This okay? Okay. Just do this. A 60-year-old male suffered from heart failure. Okay, 60-year-old male. Central venous pressure CVP was continuously measured for management purpose. In case of heart failure, we put a line, CVP line. We just put a catheter in the femoral vein and just push that catheter into the central vein, somewhat like in the inferior vena cava inside the chest. And that pressure which is recorded from maybe like inferior vena cava or maybe from inside the chest by putting a center line, that pressure is known as CVP. Now, CVP is the pressure of, it measures the pressure of what? Right atrium. If you see the heart is a 4-chambered structure. Now, this is inferior vena cava and this is superior vena cava. Superior, inferior. In central venous pressure, we put a line, and that line may go up to this point, this point, this point, this point, anywhere. Okay, so this pressure which is measured from this or this is the CVP, and this will reflect the pressure of the right atrium. Okay, central venous pressure, or you can say even the jugular venous pressure. JVP reflected in this jugular vein and the central venous pressure which is reflected from here, they are reflecting the pressure of right atrium. This okay? This may reach up to right atrium. It may reach up to right atrium. This okay, Rahul? This may reach up to right atrium, it may not reach. Whether it reaches or not, it hardly makes any difference. The pressure of this and JVP almost same. This okay? So CVP measures the pressure of right atrium. To measure the pressure of left atrium, you will do the wedging. Wedge pressure. Okay, wedge pressure will tell you the pressure of left atrium. To assess the pressure of air, we have to do the wedging. Okay, this will be done from the pulmonary artery. So right atrial pressure is CVP or JVP. Left atrial pressure is wedge pressure. Is okay. So answer here is very clear. It is the pressure of right atrium. Is okay. Okay. Yes, pulmonary capillary wedge pressure will represent the pressure of this thing. Is okay? Pranav, wedge pressure measured from pulmonary capillaries, from the pulmonary artery, just push it. That will reflect the pressure of left atrium. Is okay? Okay, let's go to the next simple question again. Pancreas is the storehouse of enzymes which can auto-digest pancreas. In case of acute pancreatitis, it can auto-digest pancreas. Okay, and that is why acute pancreatitis is a serious condition. Trypsinogen, the main protein digesting enzyme, okay, is activated after secretion by. Trypsinogen will never be activated inside the pancreas. It will be activated after it is secreted. How? It is activated by enterokinase. Is okay? Enterokinase is a fixed enzyme in the GIT. If you see the GIT, okay, from the pancreas what is released? Trypsinogen. And there is one enzyme here. It is a fixed enzyme in the intestinal wall. And this fixed enzyme in the intestinal wall, this will convert trypsinogen into trypsin. And that is why trypsinogen is never activated inside the pancreas. This okay? First come out and then you will be activated. So this is a safeguard. Okay? It's a safeguard. Trypsinogen is never activated inside the pancreas. So this is activated by enterokinase. Once small amount of trypsin is formed, then trypsin itself can convert trypsinogen into trypsin. But how small amount of trypsin will be formed? That will be initially formed by enterokinase. Is okay? So it is trypsinogen, the main protein digesting enzyme, is activated by enterokinase. Second choice can be trypsin also. Trypsin can also activate trypsinogen. Okay, trypsin is, if enterokinase is not there in the choice, then we can go for trypsin also. Okay, trypsin itself can activate trypsinogen. Okay, so answer here is very clear cut. It is enterokinase. Okay, it is the fixed enzyme in the GIT. This is done. Enterokinase. This one, A. A is the answer here. This is done. Okay. A is the answer here. Enterokinase. Don't forget the importance of this enzyme. Enterokinase. And this is such an enzyme which is not destroyed. This is such an enzyme which is 40% carbohydrate. So somehow this is not digested. In this enzyme itself is not digested by trypsin. Okay, it's a special enzyme. Okay, A is the answer here, not B. A is the answer here. Okay. Just see this question. The structure marked as A in the following diagram is, what is this structure which is marked as A here? What is this? Just see this diagram carefully and now you tell me what is this structure. What is this structure? What is this? And what is this? This is the loop of Henle. Loop of Henle. And what is this? The capillaries which are surrounding the loop of Henle. What are these? What is this structure? This is vasa recta. Okay, this structure is vasa recta. These red colored structure, what are these red colored structure? This one, red colored. These are peritubular capillaries. If you see it carefully here, then you can see the blood flow. What is this? Blood is entering into glomerulus. This is glomerulus. Okay. This is Bowman's capsule. Bowman's capsule. So blood, this is afferent arteriole. It is entering into glomerulus. Done. This is Bowman's capsule where we have the GFR. Now, blood will go this way. So these are peritubular capillaries. Peritubular capillaries. And this Bowman's capsule, this will go this way. So this is all PCT. All PCT. Proximal convoluted tubule. And this proximal convoluted tubule will become, what will this become? This will become descending limb. Descending limb. This is thin. And then this will become ascending limb. This is also thin. Lower part is thin, but upper part is thick. Thick ascending limb, thin ascending limb. The peritubular capillaries which were there, It is the same peritubular capillaries, but they are modified. Okay, they are modified, and these modified peritubular capillaries, which are long and straight vessels, these are vasa recta. Okay, so vasa recta, these are the modified peritubular capillaries which are present in the juxtamedullary nephrons, long and straight vessels. This is vasa recta. So this is a loop of Henle, and surrounding the loop of Henle, these blood vessels are vasa recta. In the loop of Henle, we have counter current multiplier, and in the vasa recta, we have counter current exchanger. Is okay? Counter current exchanger. I think now it should be clear what is this. This is vasa recta. Peritubular capillaries are this. These are peritubular capillaries. These are peritubular capillaries. Is okay? This is afferent arteriole, and this is efferent arteriole. Okay? This is afferent arteriole, and this is coming out. This is efferent arteriole. Peritubular capillaries, and these are vasa recta. Okay, I think it is clear now. PCT and DCT, they will both have peritubular capillaries. PCT, DCT, both peritubular capillaries. Right? Proximal and distal, they are both mixed here. This is PCT. It will go down, it will go up, again it will become DCT. So this is PCT, this is DCT. PCT, DCT, they are mixed, and they are both supplied by peritubular capillaries. Is okay? Counter current exchanger, Mahan Sharma, counter current exchanger in vasa recta, and counter current multiplier in this loop of Henle. Is okay? Okay. See the next question. The glomerular filtration is the first step in urine formation, and its regulation plays a critical role in the BP regulation. Not only it will play a critical role in urine formation, but side by side it is critical for BP regulation also. What is the question? All of the following factors will increase GFR except. Such type of questions are regularly asked. All of the following will increase GFR except afferent arteriolar dilatation will increase GFR. Efferent arteriolar constriction will also increase GFR. Hyperalbuminemia will decrease GFR. Increased renal blood flow will increase GFR. So answer here, very clear cut. This is the answer. C is the answer here. Is okay? Maximum students here are correct. C is the answer. Afferent dilatation increase, efferent constriction increase, increased blood flow increase GFR. But hyperalbuminemia will pull the fluid from the Bowman's capsule, so it will decrease the GFR. Very simple to understand this. Just make this diagram in your mind. Just create this diagram. This is afferent, and this is glomerulus, and this is efferent. Just develop this diagram in mind. Now analyze the factor one by one. Afferent dilatation, efferent constriction. If this arteriole dilates, so there will be more flow. So pressure here will be more. so more GFR. Efferent constriction, this is outflow, this is inflow, this is outflow. Efferent constriction, if you block the outflow, pressure here may be increased, so GFR will be increased. This is okay. Now, third, hyperalbuminemia. If the albumin here, if the blood albumin level is more protein here, so this will pull, more protein will pull the fluid. Okay, so GFR will be reduced actually. This is okay. And fourth, more blood flow. If blood flow increases, pressure here increased, so GFR increased. So simple answer here is hyperalbuminemia. If the albumin here is increased, that will pull the fluid. So GFR will be reduced. Is okay? For such type of questions related to GFR, which factor will increase and which factor will decrease? Just make it a habit. Just this picture should come into your mind. Which force will be affected? Whether it will affect this force or this force. If you have stone, kidney stone, hydronephrosis, so pressure of the Bowman's capsule will be increased. So GFR will actually fall. Is okay? So for such type of question, this diagram is critical. Just make this diagram in your mind and then analyze the factor one by one. Is okay? Then you will be able to solve it. This is done. Clear cut answer here. Hyperalbuminemia will decrease the GFR. This is okay? Hypoalbuminemia will increase the GFR, but hyperalbuminemia will decrease that. This will affect the oncotic pressure. You are right, Nitesh, Huda, you are right. It will affect the oncotic pressure. Hydrostatic pressure, oncotic pressure. Is okay? I think maximum students here are correct. GFR is also regulated by macula densa. Okay, not macula densa. Here we have mesangial cells. Macula densa is something else. Macula densa is not related to this. We have mesangial cells here, and those mesangial cells will contract, and that will decrease the GFR. So mesangial cell contraction will be another factor. Okay. Macula densa is a sensor which is present in DCT. That is not related to GFR. Okay. See the next question. A person was not getting enough water. Water was not given to that person. Okay. He was obviously he will be thirsty. He was extremely thirsty. In such a condition, one hormone which is released from posterior pituitary will act on. Where will it act? Where will that act? This is A. Okay. This is B. This is C. This is D. Something like that. Where will that act? Obviously, when you are thirsty, if I don't give you water to drink, what will happen to plasma osmolarity? Answer here is very clear cut. In such a situation, ADH will be released and ADH will reabsorb water from this portion. So answer is clear cut here. Answer is D here. This is okay. So there is no doubt about that. He is talking about ADH. My question is, if the person was not getting enough water, so what will happen to blood? Blood will become more concentrated. There is no water. So plasma osmolarity will be increased. And when plasma will become more osmolar, more concentrated, then what will happen? There are osmoreceptors present in anterior hypothalamus. Anterior hypothalamus will sense the increased osmolarity in such a situation. This is osmoreceptor present in anterior hypothalamus. It will sense the increased osmolarity. It will sense the concentrated blood. What will this do? On one hand, it will send signal to lateral hypothalamus. To generate the behavior of thirst. Thirst will be generated by lateral hypothalamus. This will send signal to supraoptic and paraventricular nucleus also. Supraoptic and second is paraventricular. And this will send signal to posterior pituitary and this will release ADH. So if you don't drink water, plasma will become concentrated. So on one hand, you will become thirsty and on other hand, ADH will be released. ADH will reabsorb water. So you will drink water, you will reabsorb water. ADH will reabsorb water from kidney. How? How this will reabsorb water from kidney? How? It will be reabsorbed from this portion. Okay? Maybe to be more precise, you can say from this portion. Collecting duct, collecting tubule, late distal tubule, this portion. Okay? In this portion, ADH will activate aquaporin 2. Aquaporin 2 will be activated by ADH. So water will be reabsorbed. So answer here is very clear cut. Is okay? Okay. Don't be confused. 65% water is reabsorbed from PCT. 65%. Okay, water is reabsorbed from PCT. Maybe some 15% water is reabsorbed from this portion. 65% PCT, 15% thin descending limb. So 65 plus 15, 80%. 5% may be reabsorbed from 5% may be reabsorbed from this portion, DCT, 5%. So 85. 10% may be reabsorbed from cortical collecting duct and 4.7% may be from medullary collecting duct and 0.3%, 0.3% may be excreted in urine. So I'm not explaining that thing. Okay. So if somebody asks you from where maximum water is absorbed, 65% PCT, that is a different issue. But ADH will control this one, 10% plus 4.7%. So roughly this 15%, roughly, this is under control of ADH. This is not controlled by ADH. In this portion, we have aquaporin 1. What is present in this portion? Aquaporin 1. This is the water channel. So aquaporin 1, which may be present over here, it is not under control of ADH. Aquaporin 2 is under control of ADH, which is present in this portion. So where maximum water is absorbed? Okay, PCT. That is a different question. So don't be confused. This is okay. ADH will act over here. So as far as my question is concerned here, so answer here is D. Dipender Singh Chahal, glucose is absorbed from where? Glucose is absorbed from early PCT, this portion. 100% of the glucose is reabsorbed from early PCT. Nitesh Huda, 5% under ADH, no. 15% under ADH. This 5% plus this 10%. Cortical collecting duct, medullary collecting duct. ADH has a control over 15%, not just 5%, 15%. Okay, I can ask you one more question. ADH will do maximum reabsorption from cortical collecting duct or medullary collecting duct? This question I can also ask. ADH will do maximum water reabsorption from, I can give you 4 choices: PCT, loop of Henle, cortical collecting duct, medullary collecting duct. Then what will be the answer? In such a situation, answer may become cortical collecting duct. But I am not entering into that. ADH will control this 10% plus this 5%. 15% is under ADH control. ADH will do more water reabsorption from cortical collecting duct than medullary collecting duct. Is okay? Leave it. From our purpose, the answer here is D. ADH will act on last part. Is okay? ADH acts more on cortical collecting duct than medullary, quantity wise. Is okay? Okay, let's go to next question. A 50-year-old male underwent TMT for cardiorespiratory assessment, treadmill test. TMT is routinely done to assess the cardiac functions. Okay. All of the following changes will be seen during such type of test except when you are running on TMT. All will be seen except. Yes. Increased cardiac output. Fine. Normal cardiac output is 5 liters per minute, 5.4 liters per minute. It will be increased and it can go up to 30 liters per minute. 30, 35, 40, maybe up to 45 liters per minute in a well-trained marathon runner. Increased total peripheral resistance. In such type of exercise, in the TMT, total peripheral resistance is rather decreased. So this is not correct. Increased extraction ratio. Normal extraction ratio is 25%. In exercise in TMT, it can go up to 75%. Yes, this is fine. Decreased kidney blood flow. Yes, kidney blood flow will be reduced. So this is also fine. So what is the answer here? So the answer here is B. B is the answer here. Okay, students find such type of question again difficult. This is okay, but this is a standard question. The standard question, what are the changes? What are the physiological changes in exercise? You are doing exercise, you are running. What are the changes which you will get? So, when you are running, when you are doing jogging, or you are on TMT, what will happen? Muscles, they need more oxygen. Okay. So muscle blood flow is increased. the blood flow of the muscle is increased. Autoregulation. What will muscles do? Because metabolites are formed in the muscle. Carbon dioxide, H plus, is formed in the muscle. So because of these and metabolites in the muscle, they will do vasodilatation. So muscle blood flow is increased. Only then you can exercise. Muscle blood flow is increased, so there is dilatation in the peripheral muscles. And this vasodilatation in peripheral muscle will decrease the total peripheral resistance. So why TPR is decreased? Because of the vasodilatation in the working muscle. So total peripheral resistance is reduced. The reason is vasodilatation of the working muscles. Vasodilatation of the muscles which are working. Is okay? So there will be more muscle blood flow. Muscle blood flow will increase and muscles will extract more oxygen also. Normally muscles extract 25% of oxygen from hemoglobin. Okay, extraction ratio may become 75%. Only then you can exercise. There will be more venous return, there will be more cardiac output from 5 liters up to 30 liters. So it will become hyperdynamic circulation. Heart pumping more, all blood going through muscles, muscle extracting all oxygen. And that is what we are trying to check in this test. What is your performance? This is okay. But because there is vasodilatation in the working muscle, so TPR is reduced. This is clear. Total peripheral resistance. Moreover, during such type of exercise, there will be sympathetic stimulation. How that stimulation will benefit you? It will do vasoconstriction throughout the body. This is okay? Vasoconstriction in intestine, kidney, everywhere. Except brain. It will not do vasoconstriction in brain and heart. So because of sympathetic stimulation, there will be vasoconstriction. Everywhere, particularly kidney, intestine, not in vital organs, brain and heart, no. So there are two things which will occur. Vasoconstriction in all the tissues. Vasodilatation in working muscle. This is occurring because of sympathetic stimulation. This is occurring because of the local factors. This is okay. So muscles are exercising, pulling more. So what happens? Blood from other organs like kidney, okay, non-working muscles, intestine, that blood is diverted to muscles. Okay. So this increased cardiac output from 5 liters to 30 liters, this entire cardiac output will not go through kidneys, through intestine. This will go through working muscles. This is okay. So decreased kidney blood flow. Yes, kidney blood flow is reduced. Why? Sympathetic discharge. And this blood will ultimately go through muscles. Now, the fact is that this vasodilatation of the muscles, of the working muscles, is more important than this vasoconstriction. This will try to increase total peripheral resistance, but this will try to decrease TPR. This is more important than this. So ultimately TPR falls. And because TPR falls, so diastolic BP. So diastolic BP will also fall. TPR falls, diastolic BP also falls. Is okay? So this is the thing which is seen in such type of exercise. Okay? So answer here is this. This is the answer. Total peripheral resistance is rather decreased because of vasodilatation in working muscle. Although sympathetic stimulation will try to increase the TPR, but this is more important in such type of exercise. Is okay? Yes, Rahul, you are correct. Sympathetic stimulation, so kidney blood flow is reduced. Idea is not to reduce the urine production. That is not our idea. Our idea is to divert that blood to the muscles. Okay, urine formation will be reduced. You are fine. Is okay? More venous return, more cardiac output. More blood is coming, more is going. Is okay? Because more blood is coming, so CVP is increased. Because CVP is increased, so heart will contract with more force, so cardiac output will be more. This is Frank-Starling law. Is okay? Okay. Such type of questions are asked. Like in this scenario, what will happen to so many parameters? So just you have to analyze. In such type of questions, you have to analyze. Is okay? These are not straight questions. Just see the next. A 55-year-old patient suffered from intracranial hypertension. Pressure in the cranium more. This is okay? Intracranial hypertension, maybe hydrocephalus, whatever is the reason. Increased intracranial pressure will lead to. This is a simple question, repeatedly asked. This is actually the Cushing's reflex. This is Cushing's phenomenon. Is okay? So what will happen here? This will lead to increased BP and decreased heart rate. This is Cushing's phenomenon. Okay, high BP and low heart rate. Very simple. If pressure in the cranium is more, so blood flow, don't be confused by such type of question. If pressure here is more, what will happen? Brain blood flow is reduced. Brain is a closed cavity. So if more pressure here, less blood flow. Is okay? If blood is more, CSF will be less. If CSF is more, blood will be less. Because brain is a closed cavity. So more intracranial tension will lead to reduced brain blood flow because of the pressure effect. When blood flow of the brain is reduced, brain will be ischemic. Okay, brain will be ischemic. When brain is ischemic, CNS ischemic response is activated. CNS ischemic response. This is activated. CNS ischemic response is activated means there will be sympathetic discharge. So blood pressure will be increased. Increase in blood pressure will try to force more blood into the brain. This is okay. So idea is clear. When the blood flow of the brain is reduced, If BP falls, you can say brain is ischemic, so it will do the sympathetic discharge, so it will try to increase the BP so that brain can get more blood. This is CNS ischemic response. But mind it, when BP is increased, what will happen? When BP is increased, because of the baroreflex, heart rate will fall. This is baroreflex. Okay, so this phenomenon is done by baroreflex. Okay, this entire sequence of events, this is known as Cushing's phenomenon or Cushing's reflex, sometimes they call it Cushing's phenomenon. So in case of a patient with increased intracranial pressure, his BP will be high, but heart rate will be low. This okay? This is Cushing's. This is done. So this is what my question is. So high BP and low heart rate. Is okay? High BP and low heart rate. This is the answer. Increased intracranial pressure will lead to increase in blood pressure because of CNS ischemic response. Heart rate will fall because of the baroreflex. This is okay? This is done. Because of feedback oscillations, this parameter can oscillate also, which you can call as periodic breathing. Periodic breathing may be because of the oscillation of these parameters. Okay, chain stroke, whatever you can call it. Okay. Because of the baroreflex, BP will try to come down. If the BP comes down more, again CNS ischemic response will be activated. Again BP will increase. Again fall, increase, fall, increase. So these parameters may oscillate also. This is okay? So that is known as periodic breathing. This is done. So this entire sequence of event, this is Cushing's. This is done. It is a standard, just a very standard explanation of that. Is okay? Okay, next question. A 50-year-old male met with an accident. He was in shock because of the blood loss. After the accident, usually there is blood loss, and because of that, he was in shock. BP was low. The figure of JG apparatus is given below. This is JG apparatus. In such a condition, the renin will be released from. Obviously, this here you have hemorrhage. Because of the blood loss, the BP falls. When the BP is low, renin is released. And the renin is released from JG cells, juxtaglomerular cells. Okay, these are juxtaglomerular cells, JG cells. This will release renin. This is okay? Juxtaglomerular cells, these are specialized cells. Okay, juxtaglomerular cells, these are specialized cells. And these are present in afferent arteriole. This is afferent arteriole. This is efferent arteriole. Okay, this thing is efferent arteriole, this thing. Okay, afferent arteriole, efferent arteriole, and what is this portion? What is this? This is actually the junction of thick ascending limb and DCT. Okay, theoretically, ideally, this is the junction of thick ascending limb and DCT. This is okay. Here it is written as thick ascending limb, but ideally it is the junction. And here the modified cells are known as macula densa. So this entire thing is JG apparatus. And here we have cells at this trijunction. What are these cells known as? Here it is written as extraglomerular mesangial cells. But these cells are also known as Lassus cells. Extraglomerular mesangial cells, we can call it as Lassus cells. Mesangial cells are these. These are the mesangial cells. Glomerular mesangial cells. What is JG apparatus? This entire thing. This entire thing. This is JG apparatus. This is glomerulus. The glomerular capillary mesangial cells, this is glomerulus. This thing, macula densa, afferent arteriole with the JG cells and these Lassus cells also. This is JG apparatus. Now the question which is asked here, that renin is released from which cell? JG cell. From here renin is released. And renin is released when BP is low. In case of hemorrhage, low BP, renin is released from here. This is done. If this suppose this JG cell is not available in the choice, then what will you do? Second choice can be Lassus cells also. Okay, so this Lassus cell should be this Lassus cell should be the second choice. Some renin is released from Lassus cells also. But no. First choice is JG cells. If this is not available, second choice I'll go for Lassus cells. This is done. Macula densa is just a sensor. It will sense the composition of the fluid present in DCT. It will sense that. This is okay. Renin is released from JG cell. This mesangial cell is a contractile cell. This cell will contract. And when this cell will contract, the GFR is reduced. This is done. So as far as my question is concerned here, that in case of hemorrhage, the renin will be released from which cell? My answer is very clear cut. It is juxtaglomerular cells, JG cell. D is the answer here, clear cut. This is okay. Yeah, Rahul, macula densa will sense the low BP, you can say. When BP is low, GFR is reduced, so the urine flow at macula densa is reduced. Macula densa will sense it, and after sensing, he will send signal to JG cell to release renin. You are right. This is the standard explanation. But nowadays, the theories are coming, so many theories. The new theory says that JG cell itself is a pressure sensor. Okay, macula densa is not required. I myself can sense pressure. Okay, so when BP will be low, JG cell will sense the pressure and he will release renin himself. So these are newer variants. Standard teaching is that macula densa will sense it. He will tell JG cell to release renin. This is a standard format. But in any case, when BP is low, renin is released. Who is the sensor? Okay, macula densa is the sensor. If somebody asks you specifically, who is the sensor? Then I will be in confusion. Whether to answer it as macula densa or whether I say that JG cell itself is a sensor. Then there will be a lot of confusion there. This okay? So you are right here. Macula densa will sense it. He will tell the JG cell to release Renin. Okay. Mahan Sharma, which mesangial cell regulates GFR? Glomerular or extraglomerular? Glomerular. GFR is regulated by this mesangial cell. This mesangial cell is a contractile cell. When this will contract, GFR will be reduced. This is GFR. So this is regulated by this. Okay, this is GFR. This GFR is regulated by glomerular mesangial cells. Is okay? Yes, Nitesh. Decreased BP leads to decreased sodium in DCT and hence macula densa activation. You are correct. But again, your theories, what can I do? Okay. They say that decreased BP will activate the macula, the JG cell directly. Okay, this is the new theory coming. Okay. But standard old books, same. Macula densa is activated when BP is low. Is okay? Okay. Just see this question. Clearance is sometimes measured to assess kidney functions. PAH clearance is, I have repeatedly told you to mug up two things. One is inulin clearance and second is PAH clearance. Okay, inulin clearance is equal to GFR and para-amino hippuric acid clearance is equal to renal plasma flow. This is equal to 125 ml per minute and this is equal to 625 ml per minute. Is okay? Even if you don't understand, just mug up these two things. Okay? So question here is related to pH. pH clearance is equal to renal plasma flow 625. This is PAH clearance. Is okay? For GFR, we can use two things. One is inulin clearance, second is clearance of creatinine. Okay, not only inulin clearance, clearance of creatinine can also be used to estimate GFR. Inulin is most accurate. But because inulin we have to inject, creatinine is an endogenous product. Okay, so clinically we are using creatinine to assess the GFR. To assess the GFR of the patient, clinically what are we using? We are using creatinine. But if I ask you which is the best indicator, then the answer should be inulin. This okay? PAH is for renal plasma flow. Is okay? Half of GFR, this is actually urea. Urea clearance. Clearance of urea. Maybe 50 to 70. this may be roughly half of GFR. Roughly 40% of the urea is reabsorbed. So its clearance may be half of GFR. Is okay? This is done. Nitesh, when there is deposition in nephropathy, then GFR may be reduced, glomerulonephritis. That may be because of the membrane, the glomerular membrane. Filtration through that membrane is directly affected. Extraglomerular mesangial cells will not do anything related to that. That is because of the property of the glomerular filtration membrane. Is okay? Is okay? Creatinine clearance may be around 140. It is slightly more than GFR. Okay, but clinically we estimate GFR by creatinine. It is very similar to GFR, but not very accurate. It is slightly more than that. Inulin is more accurate. Is okay? Okay. Let's go to next question. Primary hyperaldosteronism will lead to primary hyperaldosteronism. Aldosterone is secreted from adrenal cortex, zona glomerulosa. And what is the function of this hormone aldosterone? The function of this hormone is to reabsorb sodium from kidney in exchange for potassium and H+. This is the function of aldosterone. This is the function of aldosterone. Sodium reabsorption, potassium excretion, H+ excretion. That's okay. So primary hyperaldosteronism. This is known as Conn's syndrome. Conn's syndrome. Primary hyperaldosteronism. So obviously sodium will become more, and more sodium will indicate more BP. Potassium is excreted more in the kidney, so hypokalemia. H+ will be excreted in kidney, so urine will become acidic. Okay, and urine will become acidic, so plasma will become alkaline. Metabolic alkalosis. So it will lead to hypertension, fine. Hypokalemia, fine. Alkalosis, fine. So answer here is all. In hypoaldosteronism, you have to reverse this. There will be hypotension, hyperkalemia, and acidosis. So hyperaldosteronism, this will be seen. In hypoaldosteronism, you have to reverse it. Okay. So just try to remember the function of aldosterone. Sodium in, potassium out. H+ is also out. Is okay? So just remember this function of aldosterone. This is done. Okay, just see this question. In the circulatory system, the maximum resistance lies in. Where do we have maximum resistance? Maximum resistance lies in. The resistance lies in Where do we have maximum resistance? The resistance lies in arterioles. Resistance lies in arterioles. Mahan Sharma, hypoaldosteronism is not Addison's disease. Addison's disease is because of less cortisol. Hypoaldosteronism may not have any name as such. Okay, Addison's disease is because of less cortisol. Okay, come to this question. Where do we have the maximum resistance? The maximum resistance lies in arterioles. Arterioles are the site of resistance. Is okay? Just see this. This is heart. This is artery. This is capillary. And this is vein. If I ask you about the pressure, how much is the pressure here? 120/80. Okay, average you can take it as 93. Here average pressure 93. Pressure in capillary maybe 17 millimeter of mercury. Peripheral vein 8 millimeter of mercury. Central veins maybe 4 millimeter of mercury. Here 93, 17 millimeter of mercury in capillary, in vein 8, here 4. We call it as pressure drop. Pressure drops. Here it was 93, here 4. How much is the total pressure drop in the circulation? 93 minus 4. There is a total pressure drop of 89 millimeter of mercury. This is known as pressure drop. This pressure drop is because of the resistance. Because we have resistance, so the pressure drops. Who is responsible for maximum pressure drop? The total pressure drop 93 minus 4. Total pressure drop 89. Who is eating that pressure? This one, here 17, 8, 4. So resistance here less. Why less? Because less pressure drop. Here also less pressure drop. Where do we have the maximum pressure drop? Maximum pressure drop occurs here. Arterioles. So where do we have the resistance? Arterioles. Why there is more resistance in arterioles? We can see here because there is maximum pressure drop. Okay, I can ask this question in a different way also. Instead of asking in maximum resistance, if I ask you where do we have the maximum pressure drop, inverted commas, instead of writing this as resistance, if I replace this term resistance by this thing, in the circulatory system, maximum pressure drop occurs in arterioles. Okay, so if I am asking you resistance, okay, still you are able to answer that. If I make this slightly difficult and I ask you where is the maximum pressure drop, again the answer will be arterioles. This is okay. Pressure drop occurs because of resistance. So where is maximum resistance? Arterioles. This is okay. Okay. Just see the next question. P50 in relation to following diagram is approximately P50. P50 is actually the The partial pressure where hemoglobin is 50% saturated. At what partial pressure hemoglobin is 50% saturated? Just see this. This is the percentage saturation here. 20%, 40%, 60, 80, 100. 50% saturation. At what partial pressure? So this is 26 millimeter of mercury. This is okay. So at 26 millimeter of mercury, roughly here, hemoglobin is 50% saturated. So how much is P50? 26 millimeter of mercury. So what is the answer here? What is the answer here? 26 millimeter of mercury, not 26%. Here we have percent. 20%, 40%, 50%. And here the unit is, what is the unit here? Unit here is millimeter of mercury. Millimeter of mercury. 40 millimeter of mercury, 60 millimeter of mercury, 80 millimeter of mercury. This is the partial pressure of oxygen where, and this is the percentage saturation of hemoglobin. Okay. So it is 50% saturated at 26 millimeter of mercury. So this is the answer. Is it clear? If the curve is shifted to right, suppose the curve, instead of this, curve is shifted to right, what does it mean? How will this affect 2P50? Just see the diagram. If the curve is shifted to right, the P50 instead of 26, it may become, say, 34 in this diagram. So curve shifted to right means the P50 is increased. So P50 is increased. It means shifting of the curve to right. Is it clear? So partial pressure is 26. This is the normal value. If I ask you how much is the normal P50, again the answer should be 26 millimeter of mercury. This is the normal P50. Is okay? In, just see, 60-year-old patient suffered from cerebellar ataxia. Cerebellum, this is damaged. This is okay, this is damaged. So he will suffer from cerebellar ataxia. He may manifest all of the following features except cerebellar problem. He will have past pointing. Yes, past pointing. Finger nose test. Just ask him to do this. There will be past pointing. He won't be able to do this. Past pointing. Overshoot. This past pointing is also known as overshoot. Another name of past pointing is overshoot. This is also known as dysmetria. Past pointing, overshoot, dysmetria. Same thing. Dysmetria means you don't have the idea of distance. So there is past pointing. Intention tremor. Yes, cerebellar disease, no tremor as such. But when you do something, you have tremor. No tremor as such. Intention tremors. This is okay. Hypokinesia, fine. Difficulty in initiating the movement. What is hypokinesia? Okay. Difficulty in initiating the movement. Hypertonia, no, muscle tone is rather less. In cerebellar disease, muscle tone is less. So hypotonia is the characteristic. This is not correct. Cerebellar disease is characterized by hypokinesia, past pointing, intention tremors. Hypotonia, muscle tone is less in cerebellar disease. Is okay? So hypertonia is not there. Okay, cerebellar disease is characterized by hypotonia. Is okay? Tonia means tone, muscle tone. This is hypertonia, and this is hypotonia. This is more tone, tight muscles. And hypotonia means muscle tone is less. Go to next question. Related to this cerebellar ataxia, so many things will come in medicine. Okay? In physiology, these are the things which we can explain. Even why the tone is reduced, even that thing is not properly explained. We can't explain that physiologically. But somehow cerebellar lesion will lead to the development of hypotonia. Muscle tone is less. So many things, signs and symptoms will come in medicine. In lower motor neuron, muscle tone is less. In upper motor neuron, lower motor neuron lesion, muscle tone is less. Upper motor neuron lesion, muscle tone is more. Upper motor neuron lesion, hypertonia, hyperreflexia. Lower motor neuron, muscle tone is less. So this is flaccid paralysis, this is spastic paralysis. Okay? In cerebellum, muscle tone is less. See the next question. A 50-year-old male met with the car accident and blunt injury occurred in lumbar spinal region. Because of the car accident, the spinal cord was cut from here. Okay. Half of the spinal cord was injured. Hemisection. Car hit, spinal cord destroyed from this side. Half. Okay, not full. If full cut, then both lower limbs will go. Only half cut. It is cut on right side leading to Brown-Sequard syndrome. Hemisection of the spinal cord, this is known as Brown-Sequard syndrome. All of the following features will be seen except now in Brown-Sequard syndrome. Okay, it is regularly asked question. Regularly they ask it. Loss of touch sensation on the right lower limb. It is injured on right side. So touch will go in right lower limb. Fine. Loss of pain sensation on left lower limb. Pain will be lost in this limb. This is okay? Touch will go here, pain will go here. Loss of temperature sensation in left lower limb. Pain and temperature will be lost in this limb. Loss of proprioception in left lower limb. No. So this is the answer. Except proprioception will be lost on the right lower limb. This is okay. This is Brown-Sequard syndrome. So what will go in right limb and what will go in left limb? Brown-Sequard occurring on right side. So in right limb, touch will go. Proprioception will go. Proprioception will go. vibration will go. Localization will go, fine localization. 2-point discrimination will go. And here pain and temperature will go. Crude touch will go. Is okay? Sexual sensation will also go. And another is tickling and itch. Tickling and itch. Okay? So right, left, if you know the anatomy, then this will go ipsilateral, ipsi. And this is contralateral. So ipsilateral loss of this thing and contralateral loss of this thing. So just try to remember it. Okay? This question is simply based on Brown-Sequard syndrome, spinal cord, half cut on right side. If it is half cut here, then in this limb, touch will go, vibration will go, proprioception will go. And in this limb, pain and temperature will go. Is okay? So this is the answer here. See, again question based on oxygen hemoglobin dissociation curve. The oxygen hemoglobin dissociation curve of the patient is shifted from A to B. This thing. Curve from here to here. This can be due to this, okay? This can be because of what? Oxygen carrying capacity is decreased. Initially, I was having 20 ml of oxygen per 100 ml of blood. Now I can carry only 10 ml of oxygen per 100 ml of blood. That means either it is anemia, iron deficiency anemia, or it may be carbon monoxide poisoning. Is okay? So it can be because of either anemia. Anemia is not available in the choice. So it can be because of carbon monoxide poisoning. In anemia, curve will be like this. This is anemia. Okay, this is carbon monoxide. This is anemia. In exercise, curve will be shifted to right. And at high altitude, slight right, more height. I'll draw it again. Just see. This is the normal curve. What will happen to this curve in anemia? This is anemia. What will happen in carbon monoxide poisoning? This is carbon monoxide. This is anemia. What will happen in exercise? Shifted to right. This is exercise. Shifted to right. And the fourth one is high altitude. I'll draw it here. This is normal curve, but at high altitude, slight right and more height. This is high altitude. Okay, At high altitude, slight right, more height. More height is because of polycythemia. If hemoglobin is more height. If hemoglobin is less height. Okay, less height in hemoglobin, less anemia also, in carbon monoxide also. In carbon monoxide, it is shifted to left also. In exercise, there will be simple rightward shift. Simple rightward shift in exercise. Okay. So answer here is clear cut carbon monoxide poisoning. It's okay. This is normal curve. In carbon monoxide, this is the speciality. Less height, slight left. This is carbon monoxide. Okay. Okay. See the next question. 25-year-old female living in mountainous region suffered from severe iodine deficiency. Iodine deficiency goiter will develop. All may be seen except, simple question, in such a scenario, she will develop iodine deficiency goiter. T3, T4 will become low. As a feedback, TSH will become high. So TSH will stimulate the thyroid so that more T3, T4 can be produced. And because of this TSH stimulation, goiter will develop. Iodine deficiency goiter. So low TSH, no. High TSH. That is why goiter. Goiter, fine. High TRH, fine. As a feedback, TRH will also be high. Low 3 T4, fine. This is the answer. Because T3, T4 is low, so as a feedback, TSH and TRH will be high. Because of high TSH, I am getting goiter. Is okay? TSH level will be high. Simple question. Next question. A 50-year-old female suffered from chronic renal failure. Chronic renal failure. Okay. Non-activation of vitamin D is responsible for renal osteodystrophy. Obviously, he will develop renal osteodystrophy because vitamin D is not activated. Which enzyme in kidney is responsible for vitamin D activation? So first enzyme is 25-hydroxylase. This is present in liver. And the second 1-hydroxylase, and therefore 125 dihydroxycholecalciferol. So in the kidney I have 1-hydroxylase and in the liver I have 25-hydroxylase. So first hydroxylation will occur in liver, 25-hydroxylase. Second hydroxylation will occur in kidney, 1-hydroxylase. So this is the answer here. (24-hydroxylase) is also present, but that is not the activation. It is 1-hydroxylase which will activate that. So just remember 25 in liver and 1-hydroxylase in kidney. 125 is the active form. This is done. Just see this picture. The phenomenon shown in the picture here can be best described as. What is this phenomenon? Normal, healthy aorta. During systole, aorta expands. During diastole, it recoils back. But if the aorta becomes stiff, arteriosclerosis, maybe in old age. It will not expand during systole. It will not recoil during diastole. Is okay? So this is known as, what is this known as? Windkessel effect. What is this known as? Windkessel effect. Arteries during systole they dilate, during diastole they recoil back. So what is this? Windkessel effect. And because of this Windkessel effect, we maintain diastolic pressure. Normal pressure is 120/80. If this Windkessel effect will be lost, then systolic pressure may become 180 and diastolic may become 60. Systolic high, diastolic low. This will occur maybe in old age. So why BP is this? Windkessel effect. If arteries become stiff, BP will become like this. Is okay? So what is this? Windkessel effect. Poiseuille's law says that flow is equal to radius raised to the power 4. Radius of this vessel raised to the power 4. This is Poiseuille's law. Is okay? Laplace law is something else. Laplace law says that P is equal to T by R. Pressure tension radius. This is Laplace. P is equal to T by R. Pressure is equal to tension by radius. Ohm's law is flow is equal to delta P by R. This is Ohm's law. Current is equal to potential difference divided by radius. I is equal to V by R. Same Ohm's law. Flow is equal to pressure difference divided by resistance. This is Ohm's law. Is okay? Ohm's law is flow is delta P by R. P is equal to T by R, tension radius. This is Laplace. Poiseuille's law says that flow is equal to radius raised to the power 4. And the thing which is depicted here, healthy aorta, stiff aorta. In stiff aorta, no dilatation. This is Windkessel effect. Is okay? C is the answer here, Windkessel effect. See the next question. A 40-year-old female suffered from a benign pituitary adenoma, secreting large amount of growth hormone. Pituitary tumor secreting growth hormone. Okay? He will become, because it is 40-year-old female, so he will develop acromegaly. All of the following may be seen except acromegaly, more growth hormone. So there will be protein synthesis. Yes, there will be more protein synthesis. That is why you will have acromegaly. Fat synthesis, no. Growth hormone will lyse the fat. It will synthesize protein, but it will lyse the fat. Fat is lysed. Increased blood glucose, yes. Growth hormone will lead to insulin resistance, blood glucose more. Diabetic picture will develop. Many acromegaliacs, they are diabetic also because of this reason. Large hands, fine. Large nose, large head, large foot, large hand. Fine. Large jaw. Is okay. This is the answer. Fat is not synthesized. Fat is lysed. Protein is synthesized. Is okay? This is done. B is the answer here. Fat is lysed by growth hormone. Is okay? See this question. Brain stem has a respiratory control center. It has a cardiovascular center. It has a respiratory center also in a brain stem. It has several nuclei. The primary function of pneumotaxic center present in upper pons is to apply brake to the inspiratory signal. Just see. DRG, VRG, apneustic, pneumotaxic, and we have a pre-Bott-Zinger complex. These are the respiratory nuclei. This is anterior surface of pons, this is anterior surface of medulla. So what are the nuclei? This is DRG, dorsal respiratory group. What is this? VRG, ventral respiratory group. What is this? Apneustic. And what is this? Pneumotaxic. In the upper pons. And this is pre-Bott-Zinger complex. So just remember few things here. Number one, pre-Bott-Zinger complex. Okay, who is the pacemaker? For respiration, who is the pacemaker? Pre-Bott-Zinger complex. This is the pacemaker. This is present in medulla oblongata. This is pons, this is medulla. So in the medulla oblongata, pre-Bott-Zinger complex is the pacemaker. And second point which you should remember about the pneumotaxic center. Present in upper pons, this pneumotaxic center will project down. And what will this do to this? It will limit inspiration. Inspiration, expiration, inspiration, expiration, inspiration, expiration. So this inspiration, what will this do? It will apply brake to inspiration. It will limit inspiration. It will apply brake to inspiration. Is okay? This is the function of pneumotaxic center. Apneustic, DRG, VRG, you can ignore that. But pneumotaxic center will apply brake to inspiration. Inspiration, brake. Again inspiration. Again brake. Okay, inspiration, brake. So expire. Again inspire. Again brake. Expiration. This is pneumotaxic. So it will limit the duration of inspiration. Yes. To set the basic rhythm of respiration, no. This is the function of pre-Bott-Zinger complex. This is okay. So this is the answer here. It will limit inspiration. Okay. This is the function of pneumotaxic center. This is done. This center. It will limit inspiration. Okay. A 40-year-old male suffered from COVID pneumonitis. We have seen a lot of COVID patients. The virus produced pneumonitis. So the alveolar wall, they were damaged. So there was no gas exchange. So blood oxygen will fall. We have seen this thing. He was hospitalized because oxygen saturation was 90%. All of us, we have seen this thing. Pulse oximeter below 90 in COVID. Okay, it was because of pneumonitis. Because there was no gas exchange. His ABG was done after admission. His PaO2 will be approximately, you see the curve. You see this curve. Okay. This is the normal oxygen saturation, 98%. This may be at, maybe say at 95 millimeter of mercury. This is in millimeter of mercury. At 95 millimeter of mercury, it is 98% saturation. I have already told you it is 50% saturated at 26 millimeter of mercury. The question which is asked here In COVID pneumonitis, it is 90% saturated at 60 millimeter of mercury. Okay, 90% saturation at 60 millimeter of mercury. So if pulse oximeter shows below 90, in arterial blood gas, it will show below 60. So corresponding to 90%, it will be 60 millimeter of mercury in ABG. So if in arterial blood gas below 60, we call it as hypoxia. In pulse oximeter, if it is below 90% saturation, we call it as hypoxia. So this is hypoxia by definition, and this is also hypoxia by definition, 60. Is okay? So the answer here will be 60 millimeter of mercury. At 26 millimeter of mercury, it is P50. It's okay. See this question. A 50-year-old male suffered from head injury. Head injury. Because of injury, hippocampus was damaged. He will suffer from simple hippocampus. The function of hippocampus is consolidation of memories. Consolidation. Save. If hippocampus is destroyed, you won't be able to consolidate. So you will develop anterograde amnesia. Okay, it has been discussed in the class in detail. Okay, it will lead to anterograde amnesia. Kluver-Bucy syndrome, again try to mug it up. It is because of amygdala. If amygdala is destroyed, you will develop Kluver-Bucy syndrome. Okay. If hippocampus is destroyed, anterograde amnesia. This is done. Retrograde may be because of thalamus. This is okay. Dementia occurs in old age. This may be because of cortex. Okay, so just try to remember hippocampus for anterograde amnesia. And last year the question was asked amygdala for Kluver-Bucy syndrome. This is done. Anterograde amnesia. This is done. Thank you very much. I have discussed 25 most important questions here. Is okay? Thank you very much. Anything, if you want to ask me later on also, I am always available. Is okay? Thank you very much.